Thank you very much, and I'm more than happy to see that techniques from burns spread over the world and can also be reproduced in other places in the same way, which is very good, and this is what helps the patients. But we do have unfortunate patients, unstable slipped capital femoral epiphysis. Case like this, and I said this morning, I think it's like an acute fracture and should be treated also like an acute fracture of the hip because there is a high risk of AVN. And this is the most disastrous complication we have in these cases because very young patients, you see here, was reduced. I think everything was done fine, but it's unstable. So what do we know at this time? We have clearly altered morphology. You see this case with in situ pinning with AVN. We have literature, 24%, for example, incidence of AVN in unstable schiphis in a systematic review by aerosols. And it varies a lot, from 5 to 58% if we go to other studies with so-called unstable acute slips. But what does it mean, unstable acute slip? And I want to go to this point. And the other goal we said this morning is we need to have restoration of normal anatomy and, of course, minimize. We are not 100% perfect, but minimize the risk of AVN in this very young patient group. So our algorithm is a stable schiphis slip with an angle less than 30 degrees is mostly not taken to a done procedure in situ pinning with open or arthroscopic offset correction if needed, or just in situ pinning. But if the angle is higher than 30 degrees, I regard it as moderate or even a severe deformity, which cannot be done just by treatment of in situ pinning. There was a paper out, clinical stability of slipped capital femoral epiphysis some years out. And the problem is, you look at the x-ray, I don't know which hip is stable or unstable. Since the time period we can do open surgical hip dislocation, I know exactly which hip is unstable or not. I can see it during surgery. But the problem is, I already have made the decision for surgery in order to evaluate instability. We all know, that's known now, that if we leave deformity, we will have poor functional outcome in these young patients. So the question was, what is the AVN rate after 10 years? What are subsequent surgeries and hip pain in patients with really unstable situations? It's retrospective, of course, but it's a time period of a little bit more than 20 years. 59 hips we have classified as clearly unstable. We have a nice follow-up, 100%. Duration of symptoms, several weeks, and there are different classifications. One is the Loader classification, or the other one is the Fahey-O'Brien classification, which to me are not really helpful in defining what is instability. This was the flow chart. Maybe we don't have to go through all the points, but we are ending up with 59 hips with complete information, with not a treatment with in situ pinning, but with open surgical hip dislocation. This is the point where we can define or decide really what is unstable and what not. So we had the 59 hips. Nearly half of them severe slips. That means it's 50, 60 degrees or even more. So we know they have a worse result than mild to moderate slips. all have been treated by the modified Dunn procedure. There was also the moment to define what is instability. And of course, you know, the mean age is very young, 13 years, they are teenagers. Quite a bit of a high number of male patients, 61%. We have seen this morning how we do it. It's a surgical hip distillation, but it's extended with a soft tissue retinacular flap. Actually, in most of these patients, we do see the physis in the greater trochanter, and we can go through the physis. It's easy to break with a chisel, and usually, as you can see here, it's probably about half of the greater trochanter size, or even a little bit more. You can take away, and I'm not sure if you really have to take away that much of the portion, but even if you do it through the physis, it's easier done. It's, I think, pretty safe in these very young patients for femoral head vascularity. And even then, if you take down that much of the greater trochanter, the remnant portion, the mobile fragment, will heal back to the greater trochanter and give you a normal configuration. So I don't really see a real downside, although nowadays I tend to take less bone down than in this previous initial illustrations here. So modified Dunn is helping you to expose all the posterior aspect of the greater trochanter, of the femoral neck, and also of the head up to the insertion point of the retinaculum within the femoral head. You can see here that's, I told this morning, it's a naked proximal femur, and you can do whatever you think you need to do in this situation without being afraid to harm the vessels surgically. That's a retinacular flap. The red area is where the vessels go into the head. You can do the osteotomy from anterior, anterior superior, whatever, mobilize the epiphysis, and you still have it pedicled on your vessels, and you have decapitated actually the femoral neck, like in this situation. Of course, fixation is easy because it's open, and I would really recommend just monitor bleeding of the femoral head with either method you ever would like, if it's ultrasounds, if it's drilling, or whatever. That's the most important information you will have in your patients. Outcome parameters is the survival, hip pain, function, subsequent surgeries we might need. And you can see the AVN rate was 7% in unstable hips. So we have AVN rates over the period of 20 years, and these are the clearly unstable hips we operated with this modified Dunn procedure. Of course, there are some other salvage surgeries like intertrochanteric osteotomy afterwards, screw breakage. Of course, we have seen also before from Paolo. We do all have these problems like in treatment of, I would say conventional fracture surgery, of course. There is a little revision surgery for, you can say, for impingement, for implant removal, which I don't consider a real revision surgery or a problem. It's more problem if you have heterotopic ossifications and a limited range of motion, or if you have broken implants like K-wires, which are probably not the strongest fixation you may have in this situation. The Mel-Daubigné score in these young patients, 10-year results, remember, 17. It's quite high. Harris hip score, 95. All the other scores, very high, actually. So they have a very good functional score. Same for pain, HOS score, whatever you like to look at. You have a high rate of success. So rotation function is pretty similar to normal as long as you do not have the complication of AVN. So first case of the AVN was this case, unstable situation, 1 year follow-up. And AVN, if it shows up, it comes pretty soon. So I would say you see it within 1 year, maximum 2 years, you know this hip will survive or won't survive. No? So there was some more salvage surgery attempted with a PO, a lot of surgery, just osteotomy of the proximal femur, but you can see it didn't end up in a real perfect hip joint anymore. So once you have this complication, I would say you're somewhat on a salvage line, or you're lost actually, or the hip is lost. It still looks good, but it's a flexion extension of 70 degrees at 7-year follow-up. That's not a good hip to me. 10 degrees internal rotation, not perfect at all. Second case, AVN, even a little bit more severe, ended up in 1 year with a total hip arthroplasty, which actually is a disaster in these young patients. Next one also ended up with unstable situation, very early osteoarthritis. You can see just the head is melting away. 3 months later, there was some trial to restore congruency with proximal femoral osteotomy at 4 months' time, and she ended up in a hip arthrodesis because of pain and unfunctional hip joint. Last case, fourth case, again you can see how fast the head will go down if you have an unstable situation and no vascularization. So in only one of these 4 cases, there was a documented non-bleeding before and after reduction. In the other 3 cases, I did not find any note in the OR reports. So there were different surgeons. They are all from here, from Bern. It was all done here, Children's Hospital, and they're all experienced. So I know they're familiar with the treatment, but it still happens, especially if you have unstable situations and if you don't do unstable situations in an acute term. You can see there was always, also here there was an attempted salvage procedure for AVN, 5 months, 4 months, pretty bad hip, 5 months varisation, adduction osteotomy, and you can see the head is really melting away, and even a better overcoverage of the acetabulum did not help in the end. So these are disastrous failures, but we also have good cases, so I want to finish also with a good case. 12-year-old female with also unstable hip, acute unstable, 10-year follow-up, perfect hip function. Limitation, of course, there's no control group. It's just to show we do have problems. It's 7% AVN in unstable hips with a done procedure, but you have to realize that there are 93% doing fine. So look at also at the 93%, and we are trying to learn from the 7%, which are not very good. And if you look at the AVN rates, done procedures, open procedures, you see still with the unstable. That's the worst situation, because usually also done not in an acute mode. You can see it's only, you could say, 7%. You can see that basically done procedure is doing better than in situ pinning over a long time. So as conclusion, at long-term follow-up with the treatment of unstable hips, modified done procedure shows in our hands 7% of AVN. That's not what we like, but we're working on it, how to improve it. Key factors are correct indication, and I would say immediate surgery. Don't wait. Thank you very much.